And so we're going to introduce Dr. Shreyas Patel. He is a professor of sarcoma medical oncology and also head of the medical advisory board for the Chordoma Foundation. So he's going to be moderating the session.
Good morning, everybody. Thank you very much for coming. I know throughout the morning you've had some interesting educational sessions, if we want to call them that. I think that has set the stage for a back and forth discussion. So we're going to start off with some of the questions that we have up here. And in the meantime, if anyone wants to and has some comments, please feel free to bring that up. We want to keep this as informal as we can. So the first question, I've picked out a couple of general ones for the panel. Are there any theories or analysis as to why chordomas form?
Tony.
As you can see, the answer is so well known that everybody is looking at the other guy next door. It's a good question. I think like in most other instances, for most other cancers, we really don't know what causes it. I think as we dig deeper into some of the molecular analysis, we may have some hints as to what's abnormal in a given tumor. Whether that still is the underlying causative agent or not, I think is very hard to tell. So the simple answer is bad luck, bad genes, we can blame it on whatever, but I think if we found the true causative factor for a particular malignancy, solving it becomes a little easier. For example, we know some viruses that cause head and neck cancer, some lymphomas, and there are treatments related to that help out. Anyone wants to add anything?
Well, I think
Go ahead, Tony.
the other thing that's important too is when we think the disease has actually begun to develop and when it actually manifests are two different things. Right. So in other words, my suspicion for many of the sarcomas we treat is that they probably actually start development early on, like when you're in the womb. But for reasons that aren't clear, don't manifest until much later in life. And I say this because there are diseases such as rhabdomyosarcomas where there have been some really elegant mouse models to show that this is in fact what appears to be occurring, at least in mice, but with really good correlative data. So is it possible that some of these diseases may actually have their start early during development, but for whatever reason doesn't manifest till later? It's possible, but at least it's something to think about. I think the other thing too with a lot of our bone tumors is that if we think of these diseases as diseases of tissue repair, impairment, perhaps under the wrong circumstance, wrong time, a cell that should be doing repair gets arrested at a point that it no longer can function like a normal cell and become essentially malignant. When you look at other diseases like chondrosarcoma or osteosarcoma, frequently the types of diseases that we see appear to reflect different points of development. So our understanding of embryology, I think, needs to improve. In my opinion, I think that's where we're going to find better ways to treat these types of diseases.
Very good. So there are a few questions for radiation therapy colleagues. Why do some people have very severe post-radiation complications while others do not? David or Amol, one of you wants to take it?
Simplistically, it's the most likely thing to cause a radiation complication is dose. So if you overexpose a particular normal tissue to a high dose, you're going to have a normal tissue complication. But then, as the dose goes lower, as we use things like stereotactic radiosurgery or proton therapy, there are still, there may be some difference between individuals as to who may be more predisposed to a radiation side effect, and we don't really have a deep understanding of what that is as of yet. There are some clinical factors that we know are associated with potential for an increased risk of radiation side effects. Multiple surgeries is one that can predispose. It's why we like to do surgery one time, do it the right way, and then go to your adjuvant radiotherapy course.
Yeah, the only thing I'll add is that normal tissue toxicities are also dependent on where the tumor is located and the size of the tumor. So that's why certain patients will have more side effects than others. Then also the modality. So particle therapy is used that generally reduces the likelihood of side effects. But now we have an advanced form of X-ray therapy, IMRT, which can be delivered fractionated over a period of time. And so patients treated nowadays have less side effects, even with X-rays, than they did 2 decades ago.
Just to add one thing from the surgeon standpoint, it's mainly particular to the spine surgeon, is that we have to be collaborative about this. So when I go into the operating room and take out a chordoma and rebuild the spine, the instrumentation that I put in can have an impact on what the radiation oncologist may face afterwards. The hardware is made of metal. That metal can make it more difficult to accurately image the remnant of the tumor or the bed where the tumor used to be, and so that throws uncertainty into what they're doing. And in the case of the heavy particles, the metal can actually impact the beam and where the particles actually land. So we try to be very collaborative about this and design our reconstructions in such a way as to minimize in whatever way we can, whether it's something as simple as taking a cross-link that links the 2 rods and not putting it in the way of the area they want to treat, maybe reconstructing the anterior spine with a cage that's made of a plastic material as opposed to a metal material. And so, you know, I hope I give the message, which is so true, that at almost every level of what we do, we are interfacing and kind of trying to look out for one another, because we all have it's a challenging problem, and the more we work together, the better the overall solution will be.
On behalf of myself and our physicists, thank you for doing that too. The metal hardware can cause real problems for radiation oncologists.
Very good. So the next question could involve multiple disciplines. I guess the question is, what new treatments can we look forward to for those of us with so far untreatable or aggressive recurrences? I'm assuming the crux of this is that a complete resection has been performed before, radiation has been given, and there's still some active tumor. Maybe we start with our surgical colleagues. Do you guys feel that ablations, cryoablations, radiofrequency ablations have a role, and then we can move on to systemic therapy?
Yeah, I think the way when we see patients who have recurrence, we go through the same thought processes, because the ideal therapy would again be a complete operation. And so as a surgeon, our first question we ask ourselves is, can I do this now? And I think if the answer is yes, then that's what we pursue. If we can't, then there are we change the way we think to really make sure that we can keep our patients out of trouble and keep maintain their quality of life high. And that may require very planned, goal-specific operations where we're probably past the point of cure, but we can make a significant impact on quality of life, a positive impact on quality of life by doing an operation that takes the tumor away from the optic nerve, takes it away from the brainstem, gives a buffer between that allows maybe a little bit more radiation therapy to be put in. So I think that's from a surgical point of view. There are some evolving technologies. I think Dr. Tatsui this afternoon is going to talk about some interstitial laser therapy, which is a pretty interesting thing that's been used more and more in the brain, and as he'll explain, in the spine. It hasn't really been leveraged in the skull base yet, but I think that's another modality that, from a surgical point of view, we can look at.
Very good. So in a similar situation, I guess, if we are looking for other alternative modalities, as Tony went over with you in terms of clinical trials, a few commercially available agents and targeted therapies that we have to use, this would be an extension of that. If we haven't already discussed, which we haven't, Tony, would you comment on recent findings about PI3 kinase inhibitors?
Right. Well, so the nice thing about drug development right now is that the pipeline, I think, is more robust than ever. So whereas several years ago we would sequence and find a gene being mutated, we would say, okay, that's great, now what do we do with it? Now there are a number of clinical trials available both at our site and across the world, where, you know, if you do have a PIK3CA mutation or a P10 loss, which is basically alphabet soup, but essentially if you have these unique genes that are mutated, we now have a whole slew of trials to help. Now, I think things like the PI3 kinase pathway is really interesting, and I think it is a very complicated, oftentimes unappreciated, and I mean this in a certain way, that it's a very complex pathway that helps cells survive. And so on purpose, it has to be really difficult to deconstruct because we don't want normal cells dying. And so the key is how do you eradicate tumors with these types of mutations without affecting normal cells? And I think that's been a bit difficult. You know, in the past, if we had a drug that we would use for, let's say, mutation X, and it didn't work, we would say, oh, that, you know, this doesn't work, this pathway. But then you get into other questions like, well, wait a minute, how effective is this drug really at targeting the problem? If we're targeting this particular mutation, what else is compensating? And it turns out there's a lot of really important mechanisms that help genes, or that help pathways salvage cells. In fact, our former president, Ron DePino, has done some elegant work looking at how, you know, if you block EGFR pathway in lung cancer, you upregulate c-Met or other critical pathways that can help maintain survival. And so I wouldn't focus so much just on one area, such as the PIK3CA, the PI3 kinase pathway. I recognize that it is an important aspect to this disease. I think it's the type of situation where you're going to need to have dual therapy. So in other words, sure, block the PIK3CA pathway, but you're also going to need to combine it with something else that's going to effectively get rid of that compensation, and hopefully in the process not harm the human. So it's tricky.
So along the same lines, there's one other question. Somebody was interested in finding out about a CDK inhibitor trial in the United States.
Right.
Similar answer like Tony was giving. Clearly, it's a pathway where there is some evidence that may be upregulated in patients with chordomas. We do actually have 2, at least, if not 3, CDK4/6 inhibitors that are commercially available. There's a palbociclib trial, as I'm sure whoever asked that question saw on the website, that's up and running on the other side of the Atlantic. What about this side of the Atlantic? I think the nuances of clinical trials requires some funding, some support, and so on and so forth. The other part, from a science standpoint, I think we're also learning and understanding that not all drugs in the same class are created equal. So even if there was some evidence that a drug in a class did or did not work to a certain level in a certain disease, other agents coming down the pipeline may well be worthwhile trying it again. So it's conceivable that some of the newer generation CDK4/6 inhibitors may well make it to clinical trials here. It's not a reality yet, but I think that's a target that is of interest to the investigators who are interested in this. You want to add anything, Tony?
Yeah, you know, right now there's the ASCO TAPR trial, and there's the NCI MATCH study, and these are large-scale studies trying to evaluate whether you can match a genetic alteration in your tumor to a specific treatment. And so the NCI MATCH, I don't think addresses this, the CDKN2A question. The TAPR trial, I believe, may. Sometimes the other issue that we get into is eligibility. There are times where a patient with chordoma, for instance, may have a mutation where we say, look, there's a fantastic drug, theoretically, that could work. You send them to the people that deal with the phase 1 trials, and you find out that for some reason bone tumors or sarcomas are excluded. And so it's a bit frustrating. And that's also where I think clinicians such as ourselves maybe need to do a better job of speaking up or trying to develop more of these studies to target chordoma patients. So there are some availability at the moment, but it's limited, and part of it's going to be us forcing our way to get more chordoma-specific trials.
Back to radiation therapy. Why can't we try radiation again for a recurrence even if we have reached our lifetime dosage? I think the question relates to the risk benefits of re-irradiating a site that has already been irradiated. And they're saying that, well, the outcome couldn't be much worse. Why can't we try if it shrinks the tumor?
Yeah, so it is, we do weigh the risks and benefits of re-irradiating. I think a common misnomer is that once you've received radiation, once you can't get it again, and in many cases, it can be an option, especially if we use an approach like stereotactic radiation to target disease within a previously irradiated field. It really depends on the circumstance. It depends on what kind of normal tissue is nearby and what the risks are to that tissue. We certainly don't want to exceed the risk in damaging a nearby tissue that could cause a serious quality of life issue unless we had a good reason to assume that risk. And so it really depends on an individual's circumstance, but I think it's something that can be considered when we use stereotactic radiation.
I think it's just experience. At a big center like MD Anderson, we have some familiarity with re-irradiation and we're willing to do it, whereas smaller centers, especially in the community, they won't be willing to take those risks. I do think, as work by Dr. Raza is showing, that especially for recurrences outside the previous radiation field, there's a big role for further courses of radiation, and I think their stereotactic radiosurgery is going to have really a prominent role.
So just continuing that same theme, there is this question that says, if one part of the body has seen radiation, can a different part be radiated? I think that's an obvious answer that you guys will give.
Absolutely.
But related to that, I think, Amol, you made a comment that chordomas are radioresistant, and so the question here is, chordoma cells are resistant to radiation. What does this mean?
Well, I think that we know in radiobiology that different tumors respond to radiation differently. There are tumor types like breast cancer and prostate cancer that can respond very well to traditional fractionated radiation to a given dose. But there are other tumor types like kidney cancer and melanoma. When they receive the same dose of radiation, they don't respond as well. And so we know there's a difference in how tumors can respond to radiation, and so we term those tumors that don't respond as well as radioresistant. It's been known for decades that chordomas require higher doses of radiation to control the disease, even if there's only microscopic disease present. And that's where proton therapy has played a significant role, because it allows us to escalate the dose delivered to chordoma targets to levels that traditionally haven't been achievable with traditional X-rays. And so that's why we deem chordomas and chondrosarcomas as radioresistant, because they require more radiation dose to control them.
I think as we move forward now, not only with chordomas but with all tumor types, hopefully we'll be able to, with next-gen sequencing and other things like that, we'll actually be able to tell which tumors might be the most radiation resistant. And as we expand our radiation portfolio, so to speak, with things like carbon ions, that's made to overcome radiation resistance, because the damage that it imparts is there's essentially almost no cell alive that can repair that. It's a lethal hit. And so if we can predict that up front, maybe we can direct patients who might benefit from that towards those therapies.
Very good. So getting back to some systemic therapy related questions, and I think the theme here seems like access to clinical trials. So someone has a concurrent malignancy. There's a sacral chordoma and ovarian cancer. The second malignancy typically excludes them from participation in the clinical trial. What's a way out? I can start off. I think part of the problem is that there are some dogma, if you will, in clinical research. I think the templates of eligibility criteria typically require that there is no other confounding factor. And the person asking the question is absolutely right, that the ovarian cancer may well be under control and is not necessarily an area of concern at the time when the chordoma is being treated. But the problem is that when it's an experimental trial of a drug that is not approved for that indication, there are some basic rules, if you will, that come from regulatory bodies and are just general good clinical practice principles for clinical research, where if there is an active malignancy within the previous 5 years, that will exclude these patients from that clinical trial. And I don't know that there is any way to get around that. I think all of us who write the trials ourselves are cognizant of this. We try to put in enough loopholes that if that second malignancy is not an active process, maybe you can be eligible to enroll on the trial. But I don't know that there is necessarily any other way to get out of that. And along the same lines is this question about payments, that there are times when, let's say, a CDK4/6 inhibitor question that was here, palbociclib and now ribociclib are two drugs that are commercially available. If a patient came to see me or Tony in the clinic, we would write the prescription, and then it gets back to the fine print of the insurance program that the patient has. There are some who will be receptive because it's a commercially available agent. Off-label use of drugs in oncology is a fairly common thing. In general, it tends to be allowed. There are some who will require some justification with published literature, and we would have to write a letter and send them a paper or an abstract or something, and they will listen. And then clearly, as all of us know, all of us up on the table included, that there are insurance companies that will say no first and think later. And that does become a huge problem. And then the burden is, again, back to the clinicians recommending the treatment as to, well, what's the alternative? Can we bypass this and do it a different way? Industry sometimes has patient assistance programs and things like that. But again, as one of my patients put it one time, if you're too poor to be rich and too rich to be poor, it doesn't help the cause either. That the criteria for the patient assistance programs tend to be restrictive, and I can see why they would have written it that way, but there's always a gray zone where people get caught in the crossfire. Tony, you want to add anything?
Yeah, dealing with patients that have more than one cancer is very tricky, and we actually do see this in sarcoma often. And usually you have to triage, which is going to be the most immediate threat. If the chordoma is relatively stable, the patient's not experiencing a lot of symptoms, as much as I want to treat the chordoma, if the patient's dealing with an active ovarian cancer, that's probably going to require a little bit more of my, of our consultants' attention, being that we're at a facility where we specialize so heavily in different cancers. But no, I agree that coverage has become a much more difficult issue, and this is where it's really important that, and I know I'm guilty of it, is of publishing, more of our results, because at minimum, if there's no results available to justify why we want to give the drug in the public domain, getting access is going to be extremely difficult. And so and a lot of times we get caught up with clinic and all the other activities that physicians get caught up in, and so we don't publish as much as we want to. But in today's world, it's really paramount to get these results out, because that's going to be potentially your best way of getting some of these off-label indications for these diseases. Now, mind you, obviously we want to get an indication, but until that day happens, we have to think about how resourceful we can be with our ability to treat. So triage is important. Publishing is important, so that way we can help with justification. And but yeah, there's no good single fix, I think.
And just a reassuring comment. We're finally catching up and learning from the European Union. The European regulatory body, EMEA, has a rare cancer initiative that's been going on for a few years now. We from this country have flown over across the Atlantic there to kind of help them establish that. We're trying to get our regulatory body on this side of the Atlantic or in our own backyard to convince them that we need to have a similar rare tumor initiative. And I think as these rare tumor initiatives take some shape, the academic community is trying to come up with just registry kind of collection of data. That is, if I have treated 3 patients with a CDK4/6 inhibitor, and Tony has treated 2, and other colleagues at other institutions have treated 1 here or there, you gather everybody. You now may have data that says that, well, here is a group of 15 patients who were treated with this agent because they could get away with it and their insurance did cover it. But that's the kind of data that would help us. So one of the questions on the previous one was, is there some guidance on the appeal process? And I think the guidance on the appeal process is that we just got to keep digging deeper on to find something in the published literature that we can then take it back to the insurers as a debate, if you will, not necessarily an argument, to convince them that they should support this. So the next question for our local therapy team, I think the question reads, are there any methods or techniques for radiating surgical margins at the time of surgical resection? So Shaan, do you want to start with surgical resections and margins and then see how your neighbor can help you improve your margin?
Yeah. I sort of view my job as making Dr. Grosshans and Dr. Ghia's life much easier. In terms of surgery and improving our margins, I think, as I talked about earlier, with endoscopy, we're much better now in terms of getting margins along the bone and removing margins of tumors that once it's grown outside the bone. And I think we have a better understanding in terms of when we need an additional surgical approach in addition to endoscopy. In terms of doing intraoperative radiation to those margins, as far as I know, we don't have any methods currently available. But as Dr. Rhines mentioned, that communication between the surgeon and the radiation oncologist is important. And so similar to what our spine folks do, we do the same thing in the skull base. And so certainly if there are any margins where I'm not comfortable about it, where I feel like I may have left microscopic disease that may not be visible on the MRI scan, it's my responsibility to communicate that to the proton therapist.
Yeah, even more than communication is that being in the same place, we have the benefit of we go down to the planning computers as surgeons, and it's the insight that we have, having been there anatomically, is valuable, because you can imagine if you have a tumor, you do an operation, the normal tissues come back. And it's not the same as before. So it really requires, I think, some input from the surgeon about where the margins truly are and how much of that now more normally located tissue to bring into the radiation field. And having that co-located in the same institution where I grab a cup of coffee, walk down to radiation oncology. If I can find their offices, it's like a rabbit warren down there. You can never find these guys. But when you find them and they have the computer, you can actually help sit down, and plan the treatment together, which is a huge benefit of multidisciplinary care centers.
So I'll talk a little bit about the intraoperative as it relates to skull base. There have been intraoperative radiation studies for things like breast cancer where there may be micrometastasis very close. Typically there you give a high dose, but it's to a small area. Skull base, I don't think that's really appropriate. There's a lot of normal tissues right around there. Cranial nerves and other things. Anytime you give a very high dose of radiation, the probability of the damage to those structures could be higher. But I think, for fractionated external beam radiation therapy, you can also think about margins. And there's an impetus within the radiation oncology community, those of us who treat chordomas, to kind of standardize our margins. Because what we see, a lot of people who don't treat a lot of these use very small margins, and maybe you're not covering the entire surgical field. But you have to cover the entire surgical field, and typically your target volume can be relatively large, and that's really what's required for success. So through the particle therapy working group, there is an initiative to have experts that treat a lot of these tumors to have a consensus on how we should develop our margins.
Very good. So Tony, you showed a PET scan with some response. So the question is, spine chordoma, should PET scan be done after treatment and at what intervals?
Well, I think our surgical group actually showed a really nice slide showing how surveillance should be. And importantly, this is where I think there's an art to medicine. You know, I mean, I think as a clinician, if you feel that you can manage a patient's care with the right type of imaging for your decision-making purposes, then I don't think that you should necessarily adapt another strategy just because it's available. But so I think that PET scan imaging can be useful when you're talking about a situation where you've got disease in multiple locations. So, you know, unless the information that I get from that PET CT scan is going to change the way I manage the patient, it's nice to have the tool, but it might be, you know, a waste of money, for instance, or a waste of resources. And so, you know, anytime I order a scan, I always have to think, how am I going to use this data? And if I'm not going to use it, should I ask the patient to even consider going through it? And so I really just use it for metastatic disease. And sometimes when I'm trying to gauge response with tumors that are close to the sacrum that already have instrumentation, on CT scan you'll just see a lot of scatter. So sometimes it's difficult. And that's why sometimes I like to use the PET scan, because at least it can show me some of that activity. There's going to be some PET activity around, I think, tissues near instrumentation, perhaps because of inflammation. But there are times where you can distinctly see something that's unique, and that's where, for me, I find it helpful. Not every clinician may necessarily need that, though, for the decision making. So I think part of the use of PET scan really depends on the situation, on the patient, and the clinician involved. So I think it's one of those situations that's best discussed, you know, with your provider in clinic. You know, and while it's fancy, it's nice. There's lots of commercials and billboards out there promoting PET imaging. I think it's important to think about, well, how useful is this test really going to be? So it's really operator dependent.
Just to clarify, I think the anatomic details, is there a mass, how big is the mass, what are the characteristics of the mass, is what we get on a CT or an MRI. And depending on the soft tissues and the anatomic location, that's the test that would give us enough information. The PET CT that does the CT part and then the PET part, it adds some functional information. That is that mass that we see on the CAT scan part active? Is it viable? How active is it? How much glucose is it hogging, if you will, to use a simple term? If it's hogging up all the glucose, it makes us concerned that this is active, live, viable, growing, replicating tumor, if you will. If that information would be helpful, then the PET CT would be indicated. Otherwise, the anatomic details are much better on the CT or the MRI. So like the example Tony showed you, because we don't, I was talking to Mr. McCormick, I guess, in the break earlier, and this would be an example where if our drugs are not that good in terms of actually shrinking the tumor, if you're going to keep it stable, how do we know if it's working or not? One way we try to sort it out is if we have prior behavior that is documented, that is, if over the previous 3 to 6 months the tumor increased by 20 to 30%, and then on treatment for 3 to 6 months it remained stable, it's a no-brainer that obviously the drug is doing that individual some good. But in the absence of that prior information, it becomes very hard to make something out of stable disease on a cross-sectional imaging, a CT or an MRI. And those may be instances wherein if we don't want to throw the baby out with the bathwater, as is typically the case if we barely get our hands on a new drug that we are testing, the last thing we want to do is to call that drug ineffective because there wasn't enough proportion of patients who had shrinkage. Right? So that may be the scenario where we may build in PET scans to say, even if we could show that the glucose uptake, what we call SUV or standardized uptake values that were upwards of 10 at baseline that went down to 3 or 4 post-treatment, now you have another objective measure of some activity or lack thereof of the intervention that is being done. So PET CTs are not standard, but there may be unique situations where they certainly can be helpful.
just make one point of clarification. The use of routine PET is also limited by the fact that we're dealing with a tumor that in many cases is a low metabolically active tumor. They're slow growing. They don't do a huge amount of glucose hogging. And so if the spirit of getting the test is to look for other sites of disease, if the new site is very small and it's a tumor that doesn't have a lot of avidity for the radioactive sugar, it's not gonna be useful to see what you're looking for. So I think that's the main limitation of its routine use.
Yeah, I mean, I wouldn't necessarily use it for surveillance. It really has to be in select situations.
This is purely from the research standpoint, but as Dr. Patel and Dr. Conley mentioned earlier, right now when we get MRI scans, we just look at the volume of the tumor, and oftentimes in a patient that's had surgery and proton therapy, there's scar tissue that's often hard to interpret. And so we do have a group of radiologists doing what we call radiomics work, so looking at other MRI features aside from volume that can help predict sort of long-term outcomes. And so, hopefully in the coming years we'll have other features to look at that we can use to assess sort of response to surgery, response to radiation, response to chemotherapy, and so that might make it easier in terms of early detection of recurrence.
So one last radiation question before we open it up for discussion, unless Shannon, you have something more for us up here. What's the benefit of using a combination of photon and proton radiation?
I don't think there is a benefit, to be honest. I know some centers do it. Traditionally that's because they have limited proton capacity. Occasionally we will do it here though, and really that comes up to what Dr. Rhines alluded to. If there's extensive metal right within or close to the target volume, with particle therapy, those protons can bounce off that metal and we're really not sure where they go, so we're not sure what doses we're actually delivering. In rare circumstances, I will use photons in combination. But for the most part, we're pretty good. Our physicists are amazing, and we can actually modulate the beam around that metal hardware a lot of times, and we think we can do it safely.
So this wasn't coming from you guys, but just to round out the different particles for radiation therapy, there's a lot of data out there on carbon ions and stuff. Do you guys want to make some comments to help people put it into perspective?
Me personally, I really want a carbon ion center. We've really fallen behind in the U.S. Carbon ions are quite unique for a lot of disease sites, including chordoma. There's a lot of evidence that for these radiation-resistant tumors, carbon ions, they have a different biologic effect, and they have a different biologic effect not only in terms of killing more cells, but they also probably prompt a much greater immunogenic response. So we are pushing quite hard, and it's not just MD Anderson as well. There's been initiatives from the White House, the Department of Defense, and NCI. I think there's a realization that there's a need for a center in the U.S., not just one center, but multiple centers. And I think it's something that we start to think about, different radiation types almost as different drugs. Stop thinking so much about the diagnosis, but thinking about the tumor's capacity to repair itself. And if it can repair itself well after regular radiation, then you have to use a different kind of radiation that's more damaging.
So Larry, Franco, Shaan, but Larry, this is deja vu of the AO spine meeting all over again. So the question here is pre and post-surgical radiation. What is the approach, or when is the approach used, and what is the benefit? Is it appropriate for skull base or mobile spine as well as sacrum? So everybody gets a crack.
So that is a very good question for which I wish I had the answer. So let me first say, and I put this in the slides in my talk, even though I was emphasizing the role of en bloc resection, I concluded by stressing some of the limitations. And the biggest limitation is putting a patient through a big operation like that, getting the tumor all out in one piece, having the pathologist tell you, yes, you achieved your goal and got the thing out in one piece, and then having a recurrence in the next several years from tumor that was presumably outside of what you could see on the imaging. So you don't have to be a neurosurgeon to figure out that there's something lacking with that strategy and how can we augment it. And with the limitations in systemic therapy, the way we're most likely to augment it is with the radiation. So we like the idea, but when and how do we use it and what technique? And I do not think that this has been sorted out. Different institutions have developed their own sort of silo and ways that they like to approach, and there are pros and cons to each. There are centers that are delivering proton beam radiotherapy in substantial doses to the area, then sending the patients for surgery, and then giving more radiation afterwards, with the feeling that that improves the local control. But the price to pay for that is then you're operating in an area that just got a high dose of radiation, and the complications related to healing of the wound, healing of any fusion that you may have tried to do with the spine surgery is significantly compromised. So maybe a pro, but also a con. We also know, and one of the nice things about having these different radiation modalities in your own institution is you see the patients that have been treated with them. And although the protons and the radiosurgery to a lesser extent are helpful in many cases, there are side effects for our patients. The bone that gets radiated is weakened, and we have many patients who have part of their sacrum removed and then develop an insufficiency fracture in the remaining sacrum following the high-dose radiation. There are neuropathies because the nerves that are necessarily in that area are also seeing a high dose of radiation. So the other thing you have to ask yourself as a surgeon is recognizing that some patients will do well without the radiation. Should we be subjecting everybody to these potential complications for a bit of an unknown benefit? So some are dividing the radiation dose, some are using radiosurgery just to the tumor volume. I don't know what happens to the stuff that's outside the tumor volume. And then there are centers that adopt a philosophy like we have adopted at MD Anderson, which is if we get a clean resection, we'll generally observe the patients and utilize the radiation therapy at the time of recurrence if they have a recurrence, or in cases where the margin is not is not clean. I don't think there's a known right answer amongst these strategies. I think we all recognize that there are pros and cons to adding these things, and the challenge is we're dealing with a rare disease and we don't necessarily collect this data together. What I have argued for a long time, I wish would happen, is that the centers that are treating the majority of these patients could agree on one or two strategies, randomize patients to these different strategies and try to get some answers to these questions. But to this point, I don't think there's a right or wrong. I think there are strategies that have been adopted by individual institutions, well-meaning strategies meant to combat the challenges we all face, but we just don't know what the right answer is. And that's why in the concluding part of my slide, I thought one of the main places where we need to go over the next 10 years is really figuring out what the best way is to integrate surgery and radiation, which type of radiation and when.
Yeah, I'll say MGH is a center that treats a lot of chordoma patients as well. They've had a proton center for decades. And when we try and do collaborative protocols, it's tough even between us because we have differences in how we think the radiation should be delivered, what the target volume should be pre-op, should be post-op. It's difficult. We are kind of silos right now, I think.
There's fairly extensive experience with preoperative radiation therapy for other malignancies of the skull base and sinonasal regions, and in general, the data has been inconclusive, has not shown any particular benefit to preoperative radiation therapy compared to postoperative radiation therapy. The issues with preoperative radiation therapy, Dr. Rhines laid it all out, is that the most devastating thing that can happen is for you not to heal from your operation, because that's immediately life-threatening. And so I think things that could potentially inhibit healing are worrisome to surgeons. Especially in the skull base, we're usually communicating the oropharynx or the nasopharynx to at least the dura, sometimes the brain. And if we don't get healing there, we're in deep trouble. So without really clear evidence that preoperative radiation therapy is really beneficial. I think institutionally we have seriously shied away from that, and not only for chordoma, but for other skull-based and sinonasal malignancies.
I think there's also the anatomy of this area you have to consider. I think, within the skull base, most patients present with pretty profound symptoms related to the fact that the tumor is pressing on the brainstem and the cranial nerves. And so, in that situation, the goal of treatment is also to reverse those symptoms, to prevent them from getting worse. And so that's where, doing surgery up front has an advantage. And then, I sort of want to emphasize what Dr. DeMonte mentioned, especially with the endoscopic techniques, when we're talking about opening up the dura and potentially creating a spinal fluid leak. We rely on tissue within the nasal cavity that has its own blood supply. And while preoperative chemotherapy does not affect that wound healing, there is data showing that, preoperative radiation therapy, or patients who have had radiation therapy, don't heal as well. And, getting a recalcitrant CSF leak and meningitis after surgery delays ultimately what patients need is radiation therapy afterwards.
There was a question from the audience, right?
Do you want to ask your question?
Yeah, well, I know you kind of alluded to what I was going to. You sort of alluded to what I was going to ask. I know this. You mentioned that you can give the radiation after surgery quicker than the 3 months or 4 months that they had traditionally done, and I just was wondering how that thought process. Could you discuss that a little more?
Timing of radiation
Yeah.
therapy after surgery?
Time of radiation therapy after surgery. Yes. Mm-hmm.
I can just say a word about the spine. For us, if we're going to use the radiation therapy after the surgery, we'd obviously like to use it as soon as possible. But if we've done a reconstruction of the spine with a complex wound closure, the one thing I think I feel strongly about is we don't want to compromise that. We don't want to add to the potential problems. So we take a little bit of advantage of the fact that this is a relatively slow-growing tumor and try to delay the radiation until the wound is well healed, and in the case of the spine surgery, that the spinal reconstruction is well healed. As you probably know, we're often putting bone into the area where the tumor has been removed between the remaining normal bones to get that to fuse. It's not sufficient, if the patient is going to survive a long time, to rely solely on the metallic hardware, because like all metals, it will eventually fatigue and fracture. So our goal is to get a bony union between above where the tumor was and below where the tumor was, and that takes a while for bone regrowth to happen and span some of the sizable distances that need to be spanned. We actually go to great lengths to make that happen. We'll often take a patient's own bone from their fibula with its blood supply and have our plastic surgeons plug that piece of bone into the defect and reconnect the blood supply so that it's live bone, all in an effort to speed along this healing process so that we can then do the radiation safely. So that's how I think about it in the spine. My skull-based colleagues may have a little bit of a different answer.
I think, in terms of the skull base, the reconstruction options or the goals are slightly different. As Dr. DeMonte mentioned earlier, when we do these operations, by the time of the operation, what we have in communication is sort of the space where the brain is with the nasopharynx or the nasal cavity. And in addition, we have a lot of exposed bone that we'd expose to not only take tumor out, but also expose nerves and arteries. And so the goal of closure at the end of any surgery is, one, to make sure that we prevent a spinal fluid leak. Second of all, is make sure that any segments of the carotid artery are fully covered before we go into radiation therapy. And then third of all, any parts of the exposed bony skull base are fully covered with nice, healthy tissue, because that sort of reduces some of the complications that we potentially could see after any additional radiation therapy. And when we look with the neuroendoscopic techniques, it's usually around that 3-week mark after surgery where you have sort of a nice, healthy reconstruction where, the entire skull base has nice, vascularized tissue covering it. And I think that's different from the older approaches. Part of the reason why I think we've been able to cut down our time, that waiting period between surgery and radiation therapy, is that with the older approaches, for example, we either have to split the jaw, make an incision at the back of the mouth, and that took much longer to heal. And so that was the reason why patients typically waited 3 to 4 months or even longer before proceeding to proton therapy. And now with endoscopy, it's extremely rare that we have to make incision at the back of the mouth. And so I think, patients heal much faster. And of course, we're of the mindset that, the sooner we can get a well-healed patient onto proton therapy, the better. And so we'd rather avoid that delay.
I'll just make a final comment. I do like to wait a little bit just to, like I said, allow for that normal tissue healing, but it also allows for some of the surgical swelling, et cetera, to kind of resolve. And that helps me with my target delineation. I think I have a better picture of what to target. But also for an upfront diagnosis, primary resection followed by adjuvant radiation therapy, I think it's important to remember these are pretty slow-growing tumors. And so what I'll often say, when I show that picture of the physicist and the dosimetrist, this takes a lot of work for these complicated radiation treatment plans. And so I will give myself at least a couple weeks for that team to help me develop the very best radiation plan I can. I think that's the most important thing you can do.
A question right here.
Hi, my name is Ivan Ivanov. I'm a Chordoma survivor so far, second time. My question is how we can improve our survival rate by living a healthy lifestyle. As example, I read that acidic environment, it's helping cancer cells to grow. How we can keep alkaline environment with not sacrificing our lifestyle. Because I read that coffee is acidic. I love coffee. One more thing. I read about medical marijuana. Marijuana is killing cancer cells a lot because it deprives the cells from oxygen. But it's not legal in most states. What is your opinion? Is that thing really help or it's bullshit? Okay, thank you.
That's one of the 7 words you can't say on radio or television. Well, I'm not going to comment on the alkaline thing, but there's a lot of press on medical marijuana, and first of all, smoking is bad for you. Okay, gives you lung cancer, but and there's been a real inhibition to actually evaluating the medical effects of the active agents in marijuana because of the stigma around marijuana. So I don't think we really know what medical marijuana does other than make you feel better. I don't think there's been adequate investigation into the medical properties of the active agent THC, and I think that's the main issue. I think it's been politicized. So people ask me all the time, and I said, I don't know the answer. I mean, I think in Texas it's not legal, but I think it's smoking is not the way to deliver that medicine. I mean, I think we need to look at the medicines that are produced, that are in the marijuana plant, and figure out if they are useful medicines to use on tumors, and to deliver them in a way that's more appropriate for the tumor, and rather than using smoking it, which is the wrong thing. It's just the same. It's the same as tobacco from a carcinogenesis point of view.
I think just to add, one of the problems that we run into with a lot of these alternative medicine approaches is that the evidence supporting it tends to be weak or not robust enough. It has not gone through the scrutiny that research that happens in allopathic medicine goes through. And consequently, if you dig deep enough, you will find conflicting evidence. One paper says this, the other one says that, and so that makes it harder to sort of make it a blanket recommendation, if you will. I think at the end of the day, you as the individual sitting on the hot seat has to make the decision, well, if it's not harmful, do you want to try it or not? But it's going to be hard for anybody sitting up here to say, no, give up coffee and suffer through without coffee, pick up tea, for example, or even try medical marijuana. I think there's just not enough evidence. Tony?
Yeah, you should also be aware that, what may work for one tumor type, if you find data for it, doesn't necessarily mean it's going to work for another. I mean, this is one reason why chordoma has been so difficult to treat from a systemic standpoint is that what would normally work for many other types of cancers has zero effect on these chordoma cells. And so, you know, caution when reading the information is you should always ask yourself, well, how does this apply to the disease that I'm facing? So it's not to necessarily say that it's bad or good, it's just how does it apply? And if there's no evidence, I mean, I can't say that it's going to help you, but I also can't say whether it's going to harm you. And I just think that you want to use the best evidence available to make your treatment decisions. So just beware. Lots of non-peer-reviewed literature out there.
So let's switch gears. This is a good change. I think the next question relates more to patient assistance, patient navigation, facilitation, that sort of stuff. So maybe this is one for the panel and for the foundation. Maybe Shannon can comment at the end. So the question reads, for patients who would be traveling for treatment, whether it's surgery or radiation, how do you work with them to provide initial consultations, and who can help them coordinate logistics of their trip in terms of scheduling, lodging, transportation, insurance approvals, et cetera, et cetera? I can start if you want. I mean, I think from a institutional standpoint, each one of us has our centers. Centers are staffed with an administrative director. There's a business office. So the call comes in either by phone or online. The coordinators will help schedule the appointment. So that's the one part. They do get the insurance authorization. It's a requirement before they'll give you an appointment, or it's at least happening simultaneously. As far as the institution is concerned, I don't think that there is any established way of helping with the travel and the lodging and that sort of stuff, regardless of whether it's surgery, radiation, or medicine. Am I missing something, guys?
I think the social workers.
So social workers can help, but generally they get involved after the patient is here, is what
Yes,
my understanding is. So
that's typical.
this may relate to the initial visit, and from that standpoint, is there anything from the foundation that they might need to know?
Sure, yeah, we can help with thinking about travel and what resources there might be, as far as if you're coming from a great distance, that might help with flights and things like that. I think what's important is for patients that will have to travel, what can they do before taking on a huge step like traveling to Houston to see one of you, when they're still making decisions if they want to come here. So if you're able to do remote consultations and things like that, if you're able to do that, and how people can access that. And then, so it sounds like then if they make the decision and they're here, there are resources, social workers, and even maybe business managers can help with insurance and things like that. So it's thinking about the treatment that may be offered to them, at least some initial information about it to help them make their decisions.
Yeah, remote consultation is very difficult. And I don't know what to say about it. I think if I was going to travel or thinking about a treatment, I think you got to meet the treatment team. I think you got to sit down with these people. That clearly implies costs, travel, lodging. But so many decisions that we make are based on little nuances. And we can look at scans on a computer screen and sort of say, you can do this, this, this. But then you got to take that scan and you have to you have to look at the perspective of this is a person, and you have to really optimize your management based on not just the scans, but on the peculiarities of each individual, which are really important, and because there are clearly goals and barriers that some people will not allow you to cross or don't want to cross. For example, in the skull base, some tumors, the complete surgical removal could really result in permanent swallowing difficulties. Some people are just not willing to cross that line because that's a significant line to cross. And unless you sit down face to face and talk about those issues that are unique to the person, you really cannot give an adequate consultation. I think that's so important. And that's just what I about that. But also from a mechanistic point of view, it's a lot of institutions don't have a very robust mechanism for remote consultation. We're the biggest cancer center in the country. We don't have in every center a very organized way of doing external consultation. You think we have clinics that are packed. That's you'd have to hire a whole extra staff to be able to do the remote consultations, and you have to weigh the cost and benefit of that as an institution for institutional survival. And all our institutions in the country are strapped. We're all walking a line to keep to stay financially viable in the new age of healthcare delivery. So I don't think you're going to see any institutions spending a whole lot of money in hiring an entire second faculty to do remote consultations. I think people are going to have to continue to travel. But being ready when you travel, I think, is really important. I think is having your imaging, having your pathology, having your clinical records. All those things will maximize the time spent when you go someplace. You don't want to go someplace and not have that and then wait a couple days to get the pathology from somewhere else in the country and this and that. Having it all there at the front allows you to maximize your time when you make your visits.
And I'll also add to that, we commonly see patients that have received radiation at outside facilities as part of our routine medical record gathering. We sometimes don't get all the radiation records that we need to be able to give you an informed opinion as to whether additional radiation is an option. And so part of being prepared for consultations with us is if you've received radiation at an outside facility, gathering those radiation records and bringing it to us so that we can give you an informed opinion.
I'd also like to add one other point about when patients come to see us. Frequently, we get asked, can we do the imaging at home, and is it okay if we just send you the images and such? I would say don't think of your radiology test, whether it's an MRI or a CT, as just the machine. It's also the person interpreting the data that's huge. And so, and then the technology as well. There are plenty of great centers that have really good tech for imaging. But just like you have people here that deal with chordomas of the skull base or the sacrum, or medical oncologists that do this, we also have radiologists that spend their career looking at this. So they are extremely good at delineating one little nuanced feature on your scan that I think a lot of your general radiologists may miss on. Not because they're bad radiologists, but unless you spend a career dealing with rare diseases, you may not appreciate some of those subtle things. I mean, that doesn't necessarily mean it has to be just Anderson. I mean, there are other really good NCCN centers, but generally you want to go to a place that has high volume from the perspective that you're not just getting an expert that's just a surgeon, it's the whole team. So whether it's a social worker that can help manipulate or maneuver the system, to the radiologist that spent 20 or 30 years creating the body of knowledge that we know about radiology and tumors. So I think when you come to a center like Anderson or any other high volume center that deals with chordoma, be open-minded about the idea of doing some of the testing there, not because MD Anderson wants the testing to be done here, but because you have real people that are dedicated to doing it as best as we can.
I'll just make one comment. I agree with everything that's been said. There are some challenges to doing sort of official medical correspondence, electronically. But a lot of patients and their families will email me directly. Those are on our institutional website. And I try if I'm able to answer. Sometimes it's just answering a question or giving an idea of what can I expect, or if I come here, what's your typical routine, and oftentimes they're able to at least send some semblance of the films, not for an official opinion, but just for a what do you think, and what's the best way for me to maneuver. And I try. We're all incredibly busy with the patients who actually are in our midst, but I try to answer those questions as well as best I can, and sometimes just that reaching out is forms the initial bridge and encourages the subsequent formal consultation in my experience.
And we appreciate that you do that.
Oh, yeah.
So we have a few minutes left. I want to make sure that we did cover all your concerns. If there are open questions, let's open it up to the floor.
Can I give you
I got a question for Laurence. You keep mentioning about metal in the spine if we're doing surgery. Now, I have that also. It looked like they stopped at Home Depot and got a whole bunch of wood screws.
That's where we all go, Will.
I know.
I like Lowe's myself, but you know, I'm not going to
after the surgery is done, I found out from my radiologist that that isn't really that technique is used widely here in the U.S., but in Europe they're using a lot of carbon base, and it makes a radiologist's job a lot easier. And a lot of centers have the brass plates when they do the proton therapies. I was lucky to be able to find one that had a newer machine that had more of a matrix system of delivery, and they shot it around the metal in 3 directions to be able to get around it. I guess my question is why doesn't the U.S. start looking for more carbon-based instead of using the metal and making life hard on the rest of them?
Yeah,
I've been asking him the same question.
Yeah. You guys are very demanding. It's an excellent question, and it really speaks to what I alluded to in my comments earlier, which is we are sensitive to that, and as a team that works together, I'm well aware of what I put in and the challenges that these guys are going to face. The carbon fiber implants are a relatively recent development. And I won't get into sort of the physics of it all, but traditionally it's been very difficult to make sort of long torsional objects with the carbon fiber oriented in a way that it would maintain strength. And there are companies that have been able to do that now, but those are not approved in the United States. Our FDA and regulatory processes are difficult, and they're working on trying to get those things over here. There are challenges to using those implants. As you can imagine, when we put in metal screws and rods, we're able to bend those rods in real time to make them fit exactly the way we want in the spine. There's no way to bend a rod that's molded out of plastic or carbon fiber. So those systems are more difficult to use and more cumbersome. That having been said, there's a lot of work on changing these implants. The cages, which don't have have to perform the same mechanical function as the rod. You can imagine that the rods and screws need to keep the spine upright, but a cage just needs to stand there and support weight. We function very well by eliminating the metallic cages that we used to put in all over the place with plastic cages or the patient's own bone. The screws and rods have been a little bit more of a challenge. We're hoping to get that technology over here, but it is difficult. I'll give you an example since you asked what makes it difficult. So in order for the company, this won't name any names, but in order for them to get this sort of having any headway with the FDA, maybe the FDA comes to them and says, all right, well, we're not going to find 25 tumor cases, but if you'll do this in 30 or 40 degenerative spine cases, which are much more common, herniated discs, stenosis, that sort of thing, maybe we'll look at it. Well, now you take a disease process that's worked perfectly fine with the metal implants. You try to convince surgeons to use something that's much more fiddly. In other words, the plastic implants are not going to benefit in the degenerative world the same way they will in the tumor world. Those patients aren't going on to get radiation. So the company is asked by the FDA to find 20 or 25 patients who are getting a surgery that doesn't benefit from these implants, find surgeons who are going to put them in anyway, even though they're much more challenging to use, to support this. It's difficult to make that happen, just simply from a logistical standpoint. So we're trying to negotiate those waters because we want that. But again, we're dealing with a relatively rare problem, and so it's got its difficulties. But it's a goal worth pursuing because from the standpoint of the imaging and the lack of limitations on the heavy particles, it would be something we like. For now, we deal with what we've got, and we try to be sensitive to those issues. I don't know when those implants will be able to make it through our regulatory process.
I have a question about the CyberKnife for recurrence. If you've got the metal implants, will that affect being able to do a CyberKnife treatment?
So CyberKnife is a tool that delivers stereotactic radiation. Just take a step back. There are a lot of tools that can be used to deliver stereotactic radiation. But it works, in the end, it accomplishes a similar thing as our Gamma Knife tool and our linear accelerator. Now, in the spine, when there's a metal artifact, it can be difficult to define where the spinal cord is precisely located, and so it can be a challenge. It doesn't preclude us from doing stereotactic radiation to the spine. We have techniques. We might have to get another diagnostic examination called a CT myelogram that, which involves the injection of radioactive or radio-opaque dye around the spinal cord to allow us to see the spinal cord clearly and without distortion caused by the metal artifact. So there are ways around it, but it doesn't necessarily preclude us from using stereotactic radiation for salvage.
All right.
My wife had her procedure at a non-Chordoma expert site, University in Alabama, but she's doing well. I see Dr. Rhines in January, and everything really looks pretty good, but she does have some residual tumor. It's shrunk. She got one big radiation treatment, 24 gray stereotactic radiosurgery. If she were to have a recurrence, will it still be an option to use proton beam therapy, or would you do something else? And also, I think the lesion that's left is maybe close to her carotid artery. They did coil her vertebral artery before surgery. So it's possible that more surgery could be done and/or radiation, some type of radiation, if she were to get a recurrence.
Dr. DeMonte and I have shared a couple of these cases. There's not a lot of evidence for using stereotactic radiosurgery, especially for skull-based tumors. But yet, and sometimes...
C23, I'm sorry.
Okay. Yeah, sometimes we can go back. But then if it's a recurrence, everything's individualized. There's no, rule book. You really just have to come to a big center, hopefully, and do a kind of a collaborative team approach to cases like that. But hopefully she'll do well up front.
Yeah, excellent surgeons in University of Alabama. We would, in situations like this, we do reassess the role of surgery, because maybe the bit that's left around the carotid was simply because the avenue the surgeon had to choose to remove the majority of the tumor, put that at the farthest reach, where it just may not have been possible to get that bit, and that an alternative surgical approach may be able to address those areas that have been left behind. I don't know if that's, we have to assess that on an individual basis. But a lot of times, in Dr. Raza's study we just did, and a lot of times, if that area is amenable to more surgery, that is, and it's especially outside the radiation field, that is the way to go if we can get that get that done.
See, they watched for about 6 months, because I think about 4 or 5 different surgeons looked at it, thought it was a schwannoma. And then we got the second scan 6 months later, and it had grown tremendously. It was completely wrapped around the vertebral artery. So they did the resection thinking it was a schwannoma, thinking that they probably got most of the tumor. But then we got scanned back the next day, there was a significant amount of tumor left. They weren't able to figure it out at UAB, so they sent it to Stanford, and Stanford came back with a chordoma diagnosis, and that is when we went back in, and she had the approach here like under the jawline for the second time. So it was kind of a complex thing. I wish we'd known it was a chordoma from the beginning, but obviously we didn't. So.
It's a common story, I think.
Yeah.
I tend to be an optimist, and so I think if you look at some of the data that Dr. Ghia showed too, with the potential for upfront stereotactic radiosurgery for spine tumors, it's pretty exciting.
Yeah, I think just as a summary point, I think just to reiterate what Franco said, I think we generally look at these the same way every time. The patient comes in, they have a problem. That problem is predicated on all the things that have gone on before they came to us, and we have a set of tools, and we communicate. And we look at those tools one by one: surgery, radiation therapy, and what type of radiation therapy, systemic therapy, and we try to figure out, for the given circumstance, which of those is going to be the most effective option at this point in time. And it's sort of not about this is shut off, or that it's what are our options, and some of them may be limited. If the recurrence is, if the patient's had radiosurgery and the cord has gotten some dose and the tumor comes back in the exact same spot and is again pressing on the cord, it may be very difficult for these guys to give any more radiation therapy. Sometimes we negotiate a deal where the surgeon goes in, takes the part that is closest to the cord, the part that they can't re-irradiate, and maybe there's some other of it that can be radiated. Maybe that's a time when you're starting to think about a systemic therapy if there's a good one available. So I run the same process in my mind every time. I say, what's the problem? What are my tools? And let's look at them one by one to figure out which is going to be the best strategy or which combination is going to give us the best result. And I think we generally all do that, and in the process we kind of learn from each other.
So I
Very
think we
good.
have last question, I think,
Okay.
right here.
One more.
Okay. I forgot to ask about immunotherapy. How promising is for chordoma immunotherapy?
Need more time. It's in process. It's hard. I mean, it's always nice when you see a case here and there where it works. Oftentimes when that happens, it's because we're up against a wall and we're saying, look, this patient's come to us, there's no other option. And, we're trying to give some level of benefit, but being realistic about the expectations. But I think for us to know really how well it's going to work, we're going to need time. It's just, immunotherapy is like a whole class of different techniques. And, our immune system plays an important role in multiple areas of the body, but you have to understand that what regulates it in each part of the body is totally different. Cartilage is an inert tissue. It's meant to shock absorb. You don't want it to get inflamed constantly. It's not a good thing. Likewise, bone probably has properties too to help shield it from an overly active immune system. And so we have to figure out how to bypass a lot of that to provide benefit. And so it's something that's ongoing. I think it's an interesting area to explore, but I also think there's other areas that are really equally important. So it's just sort of casting that net over time with the best evidence available and seeing which of those things we're able to pull out that's helpful.
It's also hard from a radiation perspective. We think there's going to be a big role for radiation in combination with immunotherapy because you can produce antigens when you irradiate. But the question is, what dose do you use?
Yep.
We think if you give too high a dose, it may not work. You actually have to lower the dose a little bit, which you typically wouldn't think about for chordomas, but it's something to consider.
Very good. So let me thank the whole panel for their responses, and thank you all for coming and your participation.